All right, we'll get started. Well, welcome everyone. You are joining today the George and Fahey Center for Healthcare Innovation, or CHI's second session of the 2024-25 academic year of the Patient Engagement Lunchtime Learning Series. My name is Victoria Vasilkiv, and I will be the session moderator today. This series is accredited by the Royal College of Physicians and Surgeons of Canada as a group learning activity, and it may also be eligible for credits towards other professional bodies. We have auto transcription enabled, which can be toggled on and off anytime using the captions button at the bottom of your screen. Should you have any questions or comments, we invite you to submit them using the moderated Q&A feature, which is also located at the bottom of your screen. The session will be recorded and available for viewing afterwards. Attendees will receive this information in a follow-up email after the event. For today's session, we are hosting a special collaboration with Shared Health, and I welcome colleagues Mary Ellen Lee and Amy Foster to tell us more about our collaboration, as well as introduce our special speakers of the session today. So welcome Mary Ellen and Amy, and I'll turn it over to you now.
Thank you, Victoria. And for the introduction, so yes, I'm Mary Ellen Lee. I'm with Provincial Patient Safety with Shared Health, and we are very pleased to be joining this webinar and welcoming you, which is part of our Canadian Patient Safety Week. This year's national theme is what comes to mind when you think about healthcare harm and broadening our understanding of harm together. The idea is that patient safety is not only about safe physical care, but also about safe psychological care, ensuring that patients, residents, and clients are treated with respect and dignity while accessing healthcare programs and services. You can go to Health Excellence Canada to learn more about their series. They've got some great toolkits. Attending this webinar is a great way to participate in learning more about creating safety in the care that we provide across the province of Manitoba. Healthcare services across Manitoba are provided in facilities and communities located on the original lands of First Nations, Inuits, and on the national homeland of the Red River Métis. Manitoba health authorities respect that First Nation treaties were made on these territories. We acknowledge the harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, Métis peoples in the spirit of reconciliation. I believe that patient safety includes cultural safety care, and I look forward to this presentation. I'll take Amy in for some additional introductions.
So, hello, everybody. My name is Amy Foster. I work as the Provincial Patient Safety Consultant with Shared Health. And in collaboration with the Centre for Healthcare Innovation, or CHI, this session will explore the Canadian Patient Safety Week theme of what comes to mind when you think about healthcare harm. The session will feature a case study supported by the George and Fahey Centre for Healthcare Innovation, or CHI, preparing for research by engaging public and patient partners, PREP or PrEP award. The speakers today are as follows. First of all, we have Dr. Saint Kokochi, who is an assistant professor in the Department of Clinical Health Psychology at the Max Rady College of Medicine, University of Manitoba. She works as a clinical psychologist with Shared Health, supporting patients in primary care, community mental health, and medical inpatient settings. She earned her doctoral degree in clinical psychology from the University of Regina and completed a one-year residency at the University of Manitoba. For her dissertation, she explored the opinions of patients and family physicians on trauma-informed care using a patient-oriented research approach. From an early age, Dr. Kokochi's life journey has taken her across 6 countries on 3 different continents, helping her to deeply appreciate the significance of culture and context in people's lives. She's also a passionate advocate for social justice and inclusivity, which is an important part of her identity. She is dedicated to creating a warm and inviting environment for every individual she works with, ensuring they feel valued and heard. The next speaker is Thomas Beaudry, a proud Anishinaabe man residing in Winnipeg, Manitoba. who has devoted his life to advancing equity and reconciliation for Indigenous peoples and communities. A father of 3 and Meshum of 9, Thomas is deeply connected to his community and works tirelessly to address the intersection of environment, health, and Indigenous rights. Recently retired from the province of Manitoba's Department of Sustainable Development, where he served as the Engagement and Reconciliation Community Coordinator, Thomas now serves as Climate Change and Environment Manager at the Assembly of Manitoba Chiefs, applying his knowledge and experience to create healthier environments and communities. Thomas's experience of racism, inequity, and loss within the healthcare system has led him to engage deeply as a patient and caregiver partner in health research with the George and Fahey Center for Healthcare Innovation, as well as the Canadian Institute of Health Research. And the last bio that I'll read is for Lisa Patrick, who is unable to join us today, but was part of the work you'll be hearing about. Lisa was born and raised in Treaty 1 territory in Winnipeg, Manitoba. Lisa's mom is from Treaty 5 Roseau River First Nation Reserve, and late father was from Treaty 5 Long Plains First Nation Reserve. Lisa is registered with her mom's treaty in Roseau River. Lisa is a single mother of an adult child who is 25 years old and was also born and raised in Treaty 1 territory. Lisa does work like trauma-informed care as she sees trauma in her past, as well as friends, parents, older cousins, grandparents, and great-grandparents. Lisa does it in hope for her child and the unborn, which she sees as the future. Over the months talking and sharing stories, Lisa learned about her own traumas and other people's traumas and what has worked and what has not worked in the system. Lisa is very honored to be part of a group where stories are told and voices are heard. So we look forward to learning more about your collaboration in creating a trauma-informed care curriculum for family medicine residents, and that highlights both patient and clinician perspectives. Thank you.
Well, thank you so much for the introductions. I'm guessing this is my RQ to go ahead. I'm going to attempt to share my screen, and I have to do the obligatory ask of my colleagues here if they're able to see. Okay, thanks for the head nods and the thumbs up. So yeah, so we're here to talk about our work together in developing trauma-informed care education for family medicine residents, using the PrEP award as well as another funding that I'll mention briefly. So as Amy had mentioned, I am a psychologist in shared health, as well as an assistant professor, and also the principal investigator of this project. And I'm not sure if Thomas, you're able to, in a spot to be able to briefly just make your introductions. I can also loop back to you if this is not a good time. Okay. Maybe I'll come back. I know a line acknowledgement was just made, but I also want to recognize that and acknowledge that I am on Treaty 1 territory, and a lot of our work has been based in Winnipeg, but we in doing this project, I am working towards what's in line with TRC and working in line with the 7 grandfather teachings that some of the patient partners have generously kindly reminded me throughout our work together. I just want to note some that we, like I mentioned, that this project has been funded by the PrEP Award, and as well as the Early Career Research Grant through the Department of Clinical Health Psychology, and one of the speakers is also receiving honorarium from Kani Kanipchuk. I want to, before I pass it back to Thomas, maybe he can also introduce himself as he wishes. And if I could also ask Thomas if you would share from your perspective why trauma-informed care is so important in primary care.
Bonjour, Anin, Yidage, Megase, Zakian, and Inun, and Deshnakas. My settler name is Thomas Beaudry. I shared with my name the way that was given to me in ceremony. And why is it important, I guess, to understand trauma-informed is that everybody's going to come into the health system impacted by traumas in some way or some thing. But from an Indigenous perspective, the way we look at it is that we have blood memory. We see somebody in a white coat, it's a trigger. We see somebody in a uniform, it's a trigger. So how do we overcome that is having respect for one another, we as we go forward. So I think it's important to understand that the patients that are coming into the system, may it be into the emergency room or doctor's office, we're already being triggered knowing that we're going into something that has harmed us in the past. So we're already being defensive before we even walking through those doors. Then we got to explain what is we're sick from, or what is our impact to the person that we're there with caregiving for. So we're already frustrated before we even talk. So I guess that's the way I would look at it. So I guess maybe I'm over talking because I will share more as we go along in regards to this. So miigwech for allowing me to share and continue on here. So miigwech, I have lots to talk about.
And yes, there will be lots of time for you to also share, Thomas. It's peppered throughout the presentation for us to do a tag team. And some of the discussions that we've had as well about, as Thomas had mentioned, that trauma occurs in a lot of us, and it does occur across the lifespan, developmentally, all the way through old age, and that trust and knowledge are key components, especially for family physicians. They are usually the first point of contact with the healthcare system. And also they hold a lot of burden, or have a lot of burden in managing a lot of mental health issues. And through a lot of research too, that's shown that a lot of patients prefer or go to their family physician to treat and to seek help regarding mental health. So a lot of responsibility for a family physician. And for me, working in primary care as well, I see a lot of that. And so it's just makes sense from a provider's perspective, not as a physician, but still a provider nonetheless, that trauma-informed care is so important for all disciplines, but just for us to start with primary care. So in the remaining time that we have with each other, some learning objectives that we hope that we'll meet, and that you'll also be able to gather by the end of this session, is to identify key concepts of trauma-informed care and its role in primary care, recognize the importance of patient engagement in medical education, and for you all to reflect on how you can integrate this kind of care, and patient engagement in your work, whether in practice and research, and in whatever capacity as a professional. So I'm not sure how familiar folks in the workshop or in this presentation are familiar with trauma-informed care. Just a brief overview is there are these main concepts to it. It's primarily realizing the impact of trauma, in the long-term impact of trauma, and understanding the potential paths for recovery, recognizing the signs of trauma in individuals and clients, families, and staff as well, and everyone else who is involved in the system, in this case, the healthcare system, and respond by fully integrating knowledge about trauma into policies, procedures, and practice, and seeks to actively resist re-traumatization. So it's ideally supposed to be a systems response to individuals, but it's kind of hard to tackle a systems issue in just a small team. So that's why we're tackling with family physicians first. And the principles include safety, creating an environment that is safe spiritually, culturally, emotionally, physically as well, mentally, building on trust and transparency, being honest with not just the patients, but also each other and ourselves. Some peer support. So for physicians, it would be having peer support within physicians, but also recognizing that peer support is an important component to recovery for the people that we serve and that we work with. Having some collaboration, not just having collaboration, and mutuality, that there are two experts in the room. When you're with a patient, you as a medical professional has the expert in diagnosis and treatment, but also the patient and their caregivers are experts in their own lived experience. Creating a sense of empowerment and giving choice to individuals. A lot of times trauma survivors are stripped of their power and options when they're going through a traumatic experience, and that carries is carried with them throughout their lives. And also being sensitive to cultural, historical, and gender issues. And we really try to highlight that in our work together. So in looking at trauma-informed care education, before this project started, looking at what is available in Canada and as well as in Manitoba. So there are some that exist both at the undergraduate level and the postgraduate level. But the level of patient engagement is unclear if at all patients were engaged in the development, delivery, and evaluation of the curriculum. And the literature shows that having patient be engaged in the process can really address some of the issues that are brought forth and can enhance the learning experience as well. So for folks who have engaged patients in curriculum development, the learners have noted that the education was more culturally responsive, more culturally sensitive. There was more awareness of healthcare disparities, and they felt empowered to advocate their patients and the people that they're working with. But you know, that having patients engaged in curriculum development really hasn't been adequately addressed in research or in medical education. So we wanted to take that opportunity to do that and really disrupt the system and also just hear from the patients what it is that they want physicians to learn as it relates to trauma-informed care and also their experiences. So so we applied for a grant, and our two main research objectives was to first assess how best to engage patient and family partners as well as resident learners in developing this curriculum. And then the secondary, well, really, we say secondary, but our primary goal was to develop the curriculum for family medicine residents and family physicians. So through using some of our connections, we made an intention to recruit individuals with diverse backgrounds and with special consideration for folks who identify as Indigenous, immigrant, or refugee, and within the gender, sexual diverse community as well, with a range of lived experience and prioritizing individuals who have barriers to care. So we had proposed to have 5 patient and family partners from Indigenous and newcomer communities by using the poster that you see here on the screen and asking these community groups to advertise on our behalf. And so we have a sizable group for our team members, a mix of community members, resident learners, physicians, psychologists, and research assistant. So this was our first proposed approach. So for every meeting, we had a post-meeting reflexivity, which is done online. And so we had our first meeting with the idea of building the team and also looking at what might be some outcomes, and then meeting again for learning objectives, and then through an iterative process to keep on meeting until we have the final product. So we undershot by quite a bit. Because in reality, this is what happened. We ended up meeting maybe a total of 17 times, 17, 18 times. And we just wrapped up a couple of weeks ago for end of study. And then we're just in the process of collecting our end of study with reflexivity and analyzing that. So general feedback from team members was, based on the survey, was that they felt heard, understood, and respected, that we worked on what was on the agenda, and that the clinician scientist approach, so that's the physician educators and the psychologists, that non-community members, we're all community members, but like, non-patient partner and non-learner partner team members, that so they said that our approach was rated as a good fit. And our team process evolved as we got to know each other, and through the qualitative feedback, both on the post-meeting survey and as well as through discussions, that we've really created a sense of community within the team. It's been 2 years since we started working together, almost 2 years, shy of 2 months. And we've really, through having in-person, hybrid, and sometimes exclusively Zoom meetings, that we've had some really deep and really also difficult conversations over coffee, snacks, tears, laughter. So we've really created a sense of community with each other. But I don't want to keep talking about it because I want Thomas to share more about what it's been like working together.
It was awful. No, just kidding. I'm kidding. I'm kidding. Kidding. You always got to laugh. That's one of the things that I believe in sharing is our laughter. Laughter helps. This whole process was awesome. Become a family. We understand one another in a different format. We're able to talk freely and openly and share our heart and our mind. But along with that sharing, we were able to work together and develop a curriculum, which was our goal in the first place of how we go forward with this. And I think from a patient perspective, we felt intimidated at first. I'll speak for myself. I can't speak for the other patients and partners, but the intimidation is always there because the doctors, we understand they go to school for a long time. With my knowledge that I'm sharing is what I learned from my elders, what I've learned through experience, what I've learned through my understanding of our health from an Indigenous perspective is a little bit different than sitting in a classroom and opening a book to learn. Ours is more of sharing. Ours is more of trying to feel. We are feeling, as human beings, we are feelers. Sometimes we forget about that. We get in our head, and that's where we stay. I know what's best based on what it said on page 79 of how to heal the heart. But where is my heart? It's not here. It's here. So we got to come from here to be able to come out here when you talk to that patient. And we forget about that. And the other thing is when we're in this, what we've learned together grouping this is that the openness by the professionals as the doctors or the medical people that were with us, they were willing to learn what we were sharing. Is that willingness to learn from us. But it wasn't the way we thought that we were trying to tell them they needed to do this. We shared with them that maybe this might help from our perspective when you're working with us. And they were open to that. And that made us feel, well, made me feel being included and inclusive of what was being developed. So once we built that, it didn't happen in one meeting. It took several meetings. It took us time to feel each other out. It took time to really listen to one another, but we did it with respect. We did it with humility. And one of the things that I always stressed, I don't like meeting like this online because there's no connection. We see each other, but there's no connection. Where is our spirits talking to one another? Where is our spirits feeling one another having a bad day or a good day? So it's great that we can meet like this, but we're missing the spirit of connection that is needed if we really want to go forward together. Because how do you really heal somebody by talking to a screen that's only, what is it, one-dimensional, two-dimensional, when there's so much more to us than this. So how do we do that? It's meet. We did hybrid meetings and we did in-person meetings, which was, it helped. Biggest thing that we shared with one another is we ate with one another. Eating is so important when you meet, because when you share food with one another, you see our not so good side, because we're chewing. We've got dripping down our chins. But we're showing that we're humans. Humans are not perfect, but we share that with an open mind and an open heart. That's okay. Because do you remember when you were young that you sat around the table and you couldn't wait to share something with your parents or your grandparents? You couldn't wait to share something about your brother that they did something wrong? You know, it's how we do this. It's that in-personness. We would laugh. Yeah, he fell down, he cut his pants or he split his pants open. But then your mom or your dad would go up to the person that did that. It's okay. It's only a pair of pants. So you would be laughed at, but you would also be comforted within that circle. And that's how we developed this. We developed it into a circle that nobody was above and nobody was below. We all were treated as equals, and our voices were treated as equals. It wasn't from the professional people that were making sure it was only their voice heard. It was us as a patient having an equal voice to develop this together. And that's how we came together to develop this, and how they can reach out to us and ask us a question and we'll answer. Sometimes I don't, but because I'm not always around. But I try to help as much as I can, the best I can. If I can't do it, I try to find somebody that can answer it for it. Especially when it comes to an Indigenous thing. I know about this much, I always say, but I share lots. And understanding that I do not speak for all Indigenous people. And that's one of the things I always stress. I only share from what I know and what I've learned. But I can't speak for all the Indigenous people. Well, I'll say Anishinaabe, which I am. I can't speak for all of them, because I can't speak for the Cree, but I could speak from my perspective as an Anishinaabe man who has experienced racism within the health system, experienced the trauma and how I was treated by them not listening or listening. And I will share that. And that was the whole idea of how we came together. It took a while. We had to feel each other out. We didn't always agree, but we self-reflected. And that's the good thing. We were able to self-reflect and come back to the next meeting better and stronger together. So miigwech for allowing me to share, and especially miigwech to Sent to bringing us together this way, and how we worked together, because she facilitated very well, everybody having that voice, making sure that our voice was heard, but also making sure that the professional's voice was heard. And she brought us in there and we became family, I believe, because we were able to say that. Like, we had a wrap-up meeting, what was it, last week?
Yeah,
And
the
everybody, I
18th.
felt all that sadness that and like I said, it's Bimont is a win, it's the good life, but it's also about, it's not goodbye, it's until we meet again. Because we are going to meet again, because we are going to help each other as we go forward. We might have questions. We might not reach out tomorrow, but we might reach out in 2 years. But we know that you're there with an open mind and an open heart. And that's what we've developed in our relationship by working together, is knowing that we can trust somebody to ask them a question. And that's the way I think, as a patient, listening to the doctor, is develop a relationship with us first. And the biggest thing I always say, Anishinaabe, what it means, we are human. So when we go to a doctor's, or if we go anywhere where it needs to be, we need help, we want to be treated as a human being first. Not the color of our skin, not the number that you're going to apply for at the federal government to top off some funding from the provincial government. We're not just a stat. We're a human first. And that's what we want to feel when we go into any place looking for help, for health. May it be mental, physical, emotional, or spiritual. We want to be looked at as a human being first. Then we could maybe sit and feel that from you. That's that connection again of spirit. You can't feel that when you're talking to one another this way. You can't feel that spirit. And so you're expecting patients to talk to you about their health concerns when there's no connection. So you're going to get maybe 1 or 2 words based on the question that you're asking. Where do you hurt? My left side. Well, because there's no connection. Then the doctor or the person that's trying to heal us feeling frustrated. No, whereabouts on your left side? Well, on my left arm. Well, where in your left arm? Imagine now if you're working together face to face, you would touch where they said because they're going to point here. But when you're talking this way, you're just talking and answering based on the question. And that's one of the things that we work through by developing our relationship is how we communicate. When do we talk? How do we interrupt? Because those are so important. Because we want to hurry up and answer sometimes without self-reflecting. You're thinking you're helping. As an Anishinaabe people, no, I'm the bad one for that because my partner tells it. Sometimes it's good just to be silent and listen. When we're talking to one another, I don't want you to save me right away. I just want you to listen. But I have to be part of that healing process after we listen. Not for you to save me or heal me. I need you to help me to help heal myself. Because if I'm not part of the healing process, how do I heal? Miigwech for allowing me to share, and Miigwech to send for everything she's done in regards to this. And hopefully, it'll be shared within the curriculum soon at the university. So fingers crossed. Maybe we can influence some of you to ask for a demo. But so Miigwech.
Well, thank you so much, Thomas. Well, I can sit here and listen to you talk all day. You're such a wonderful storyteller, and a lot of all our patient partners are really good storytellers if you do take the time to just listen and create the space. So I think over there, we were reflecting a couple of weeks ago over the course of the time that we've known each other, we've seen growth in comfort and team members speaking up more and sharing more, including myself. I just wanted to share a little bit of my personal reflections as well, and noticing as I say this, some emotions are coming up because we had wrapped up our study, at least this space, a couple of weeks ago. So I think up and foremost is humility and respect that that I don't, like Thomas said, I don't know everything, and what I know is very limited. And just submitting to that and hearing out every team member and listening to their stories and what they bring to the project. And a lot of respect as well. There are certain times where there's a lot of discomfort that comes up, and just sitting with that. And as a facilitator, seeing the physical room and monitoring the Zoom room as well. On my part, it demanded a lot of flexibility, and we have 2 hours together, so that's pretty finite given all our schedules. But within that 2 hours, not being so rigidly held onto the agenda. There are some times where I would always send out the agenda a week in advance, but there are times where I'm in the room and it's like, okay, I got to let go of that agenda, even as a facilitator, because what's needed in this moment is building relationship and just hearing what's happening in the room. Flexibility also in terms of scheduling. We started first in community center, pivoting to then the Bannatyne campus. Knowing we didn't have much funding left if we kept meeting at community sites. but being flexible in all different ways. Sometimes some folks will say they'll show up and something comes up and they're not able to make it. Sometimes it's also monitoring the email while being a facilitator, while also trying to be present in the meeting because something's popped up and I need to address whatever the team member is emailing me about. Being comfortable with the uncomfortable, like I said, lots of times where I just sit there with heated discussion, not knowing where things will go, but trusting that we have enough trust in each other to be respectful and that things will work out. All of this work has also informed my clinical practice. I reflected that with some of the team members when we met last time. It's just really changing the way I've been taught is through the DSM, the Diagnostic Statistical Manual, where we'll, as a psychologist, we look at what the symptoms, we also contextualize a little bit, but just now sitting with the person in front of me, like, who are you as an individual? What is your story? What do you bring? And how would you want to work together? And also being a bit more courageous when I see things that are just not sitting right and just making some bold moves and hearing how courageous some of all of the patient partners and learners are as well, just giving me some courage as well. Knowing that I have this team to go back to every month, even though I can be so tired, we often have it on Friday afternoons because that's what works best for some of our clinicians, including myself. But Friday afternoon, a lot of us don't want a meeting Friday afternoon, but for me, I look forward to that, knowing this is how my week's gonna end because of the community, the family that we've built together. And so it has really been a rich and rewarding experience for me, and I hope folks will try it out if they haven't already, and maybe some folks will agree if they've already been working with patient and family partners. So at the end of all of this, we were able to create a curriculum, a 3-hour long academic half day that introduces the concept of trauma-informed care. I say introduces because 3 hours is not a lot of time to talk about this. We can talk a whole week about trauma-informed care and we're still just scratching the surface. So in terms of the content, it's a mixed modality for sharing this knowledge through stories, video clips, and experiential learning through small group discussions. And in line with TRC, as well as that we find it would be important, not just find, we believe that it would be important to have an Indigenous traditional helper present throughout to support learners. So that's going to be an integral part of the curriculum as well. I just wanted to share with you the outline that we have as of a couple of weeks ago. So it's a full agenda. You'll notice there's a consent to pre-measures and also the wrap up with the evaluations because we want to make this into a research project as well moving forward, so that we can pilot it, see how effective it is. But if you were to do once we finish the project, collected some data on its impact and effectiveness, you can probably just take out the consent part, but maybe not the pre-measures and the evaluation, because that's always helpful to know how you're doing, how this curriculum is impacting learners. So I will share the slides, and you can also have linked to those YouTube videos that I highly recommend that you watch. Beyond the cycle of trauma is you do have to purchase that, but in our future discussions as a team, we can think about how we can still deliver this without paying for the video. So we hope to, as I mentioned, pilot this project with family medicine residents coming up real soon, actually, hopefully this academic year, 2024-2025. And we hope that this would also lead to faculty development for family medicine preceptors, for educators, and depending on how the department wants to utilize this as well to keep educating both residents and the learners. Sorry, residents and learners, faculty. Once we've piloted it, once we've refined it and have a decent working copy, maybe a Creative Commons license so that it could be distributed widely, publicly, and then adapted to other specializations as well. So if folks in the room are interested in collaborating for future iterations, feel free to email me. I guess, Thomas, do you have anything else that you'd like to add?
Where do we start? I guess that's the problem. I know we're time limited, but that's okay. I think for me, losing a niece on the ER floor after she gave birth to a nice, beautiful baby girl, went to the hospital. They thought she was a drug addict because she was in so much pain and disheveled, and she just gave birth. It's trauma. It's not me directly, but it's still my family. It's not me. If it wasn't my family, it's still trauma because seeing a young person die over ignorance, it's trauma. My partner almost dying from sepsis, waiting 36 hours because they didn't know what to do, but talking around me. That's why I got involved. 7 years, well, 2017. So it would have been 2016. This all happened. I wanted to be a voice because she couldn't be a voice for herself. And what was the thing that they were trying to make her sign? Was a sheet to say, yes, that they're not held liable if anything happens to her. How can she sign something when she's delirious, not knowing where she is at, but they wanted that? We're not afraid of death as Indigenous people. We just want to know what's going to happen. Are they going to die? And they wouldn't talk to me. The reason being is when I did hear them, we don't know if we can save her. When they were talking in their circles, I went up to, excuse me, I need to know what's happening when she's going to die or not die. It's none of your business. I said, yes, it is. I'm her partner and I want to know. They phoned security on me to try to restrain me. And I said, you know what? We need to know because I need to bring her kids in so they can take her last breath so it could be passed on to her grandchildren. They didn't understand that concept at all. But if we're able to understand that concept, maybe the trauma wouldn't have been so hard on her, so hard on me, and so hard on the medical people. We have a different way of looking at death. We understand death as part of life. The churches are ones who put into our head that a death is something to fear. But that's not our way. We are reclaiming our way slowly and understanding who we are as part of life. It's there. It's called blood memory. We're learning slowly again, but we're supposed to share that. If we don't share it, then it doesn't mean anything. And being part of this as a patient and patient caregiver is helping me being able to share it and for others to learn. But I'm also learning that why doctors or professionals look at it a certain way. Doesn't mean that I want everything changed. I just want to be heard. And this development and being involved with our SPORE unit here and other research projects, it's giving me that voice, but I'm also learning how to share with other people. Doesn't mean that, oh, it's all this way is the best way. That isn't the true way. The best way is as we come together to learn and share what we know together. So for me, to work with us as a patient or a caregiver is hear us. Hear us with an open heart first. And then take that heart, whatever medicine that we've given you, and put it in your mind to be able to speak for us. That's what we hope. Doesn't mean it's going to happen overnight. Doesn't mean it's going to happen in 10 years. But at least we're making an effort to make that change together. So thinking about all of that is hopefully by the time my grandbabies become young adults, they will be heard as a human being, Why is it when we go to the ERs where Indigenous people or Native people or First Nation people are greeted by security first? You look at the other demographics, they're escorted and pointed to the triage center right away. I sit there and watch when I'm in the ER and observe. Why? We're humans. Look at us as a human. We're there because we're hurting. I'll share a story in regards to ceremony. I don't know if you understand what ceremony is from an Indigenous perspective. It's where you go to get healed or you go to pray and you go to work together. Some of our people say, oh, you can't come around here drunk or you can't come around here under the influence. Finally, one of the teachers, knowledge holders, the healers walked up, stopped everything and says, don't shoo them away. Their spirit brought them here. This is when we should be helping them. Their spirit brought them here for help. So why are we pushing them away when their spirit brought them here for help? Does it mean because you're under the influence of drugs and alcohol that your spirit doesn't know? So imagine us going to a hospital under the influence, looking for help, and we're being shooed away. What is that telling us? We're not good enough to be healed. May it be within my own ceremony, or may it be within the Western way of healing. That's telling me in my spirit that we're not worth to be saved. So we go out and self-harm ourselves again. That happened to my son. He's gone. He died 2 years ago due to the street taking him. But he always looked for help. He was always looking for help. But they wouldn't take him. They just looked at him as another druggie. I always told him I loved him no matter what. But don't whatever your choices you're doing, don't bring them to me. And he never did. But he would meet with me when he wasn't under any influence. But he knew that I loved him no matter what. Imagine now us coming into a place of healing and knowing that we are loved no matter what, how that conversation will change. And how that healing together will advance quicker. Miigwech for allowing me to share.
Thank you, Thomas. And I don't have any final words to say, but I do appreciate this opportunity, and I'll hand it back to Victoria and our other facilitators for Q&A.
Thank you so much, Zane and Thomas. This has been such a reflective session. It's been wonderful. The audience is welcome to submit questions or comments in the Q&A section. I don't have questions right now, but lots of gratitude being expressed for you sharing your stories, and also just condolences to you, Thomas, for your loss as well.
I've seen one of the questions are calling me doctor. Well, thank you. I'm not a doctor. I am me. Somebody is a patient and somebody who shares. And I guess Carolyn knows how I probably will. When they sometimes try to introduce me, I'm an expert in this field. And I always state to them, I am not an expert. Because I believe an expert, once they're an expert, they don't have to learn anymore. They'll continue telling us tell us what to do because they're the experts. Well, I'll never want to be an expert because I want to learn and I want to share. And I want to learn from the people that I'm sharing this with. So I'll never be an expert. My name is Gidage Megazé Zakian Ininu, and my settler name is Thomas Beaudry. That's who I am. So thank you for the title. It'd be neat to run around with a stethoscope or a white coat, but no, that would not be neat. So I played one as an extra one time in a movie, but that's different. So miigwech.
Thanks, Thomas. And also welcome any of our co-hosts or panelists. If you have any questions, you are also welcome to ask.
No, just thank you again for reminding us of the spirit, the heart, and that we have to connect with our mind and listen. And I've always valued listening and learning, and that I have my knowledge, but the families I work with, they know who they are, and their story and how their health is affecting them. And so this is just really powerful messages, so I thank you so much for sharing.
I would definitely add thanks so much, both Thomas. It's always a privilege to listen to you, and Saint. It's wonderful. It's just so wonderful to see how the Prep Awards actually being used and to bring people together and do this really important work and build family, right? So I'm so grateful to both of you for this wonderful talk.
We've got more things coming through as well. Just some comments that this is very important, especially not turning folks away, and that's really appreciated. We do have one question. Maybe you can also, we have a bit of time left. You can speak to this together. So I quote, please, is there any course I can enroll in to know more about Indigenous community as a new immigrant who wants to practice medicine in Canada? I see Saint is also writing a text response, but we could also maybe chat a bit about it if you're available.
Yeah, I was just sending my my email address there, so feel free to reach out to me as it relates to this curriculum. I'm not a physician, so I don't know how in regards to like the actual practice of medicine, but if you want to email me once we have like next year, once we have a final or a revised draft, happy to discuss with the team to share further. And Thomas, I don't know if you have anything to add with regards to that question.
Well, that question in regards is at the university, the Truth and Reconciliation Commission is there. Reach out to them. We have the Treaty Relations Commissioners at the Forks. Reach out to them. We have Ongama Wazin, that is part of the university, which is an Indigenous healing area or a way to work with Indigenous peoples in the institution. Reach out to them. Go reach out to the Assembly of Manitoba Chiefs, Manitoba Métis Federation, the Inuit, to ask them. I always say, if you don't ask a question, it'll never be answered. Is there a right way and a wrong way to ask a question? If it's asked with respect and humility, there is no wrong way or right way to ask that question. So there's different ways in regards to learn about Indigenous people. Sometimes it's just being open-minded and an open heart while you're around Indigenous people. When you're walking down the street and you see an Indigenous person living on the street, what's your first instinct? Now look at yourself and reflect, why are you acting that way? Especially as a new immigrant. What were you told? Because if you self-reflect now a little bit, where you came from, you might have had people living on your streets. And why were they there? You would ask yourself. Sometimes that self-medication is because we went for help and it wasn't there. So we self-medicate. When we leave our communities, everybody doesn't have IDs. So you go to look for a job, but you can't get a job unless you have an ID. You go to get an apartment, you can't get an apartment unless you have IDs. But you can't get an ID unless you have an ID to prove who you are. So what's the best thing to do? Well, I'll live on the streets until, but you don't have a mailing address. So how do you get your IDs mailed to you? So self-medication is a way to not feel yourself in that situation of being humiliated of where you have to be. So to learn about Indigenous people, I gave you some places to start. There's Indigenous classes, there's Native studies at the universities. Maybe go to a powwow, that's part of reconciliation. Look around at some of the Native organizations that are out there. I always say, it is not up to us to tell you who we are. It's up to you to go and look and ask those questions out there that are out there. So, miigwech for allowing me to share again. I'm kind of in a different place right now too, because we have a report that just came out in regards to missing children from the residential school that's being announced, and how denialism is impacting those graves right now, and people are saying it never happened because there's no bodies being found, but only emptiness of a shell of where a body could have been. And we say, well, now you go to a graveyard and you say that's where they're buried of your own, but there's no body there anymore. Does that mean there was no body buried there? So that's another impact to us as regards to trauma. And how do we overcome that? Because now we have to deal with people saying, well, none of that was true. So it adds to our trauma also. So that's where my head is kind of at the same time I'm here. So I'd share with you how I'm feeling. So, miigwech.
Thank you so much for sharing, Thomas. It looks like we are just about to hit our time. So maybe I'll take a moment to wrap us up quickly. I just want to take another moment just to say a wonderful thank you to Saint and Thomas for joining us today and your expertise. You might not call yourself experts, but you are definitely experts in some ways. For also your reflections today have been, I think, leave a lot of us to think about a lot of things. I also want to say thank you to our audience for attending the session today. If you are curious to get slides or the recording, that will be followed up with you via email. And we will be back with this series on November 12th for the session titled Engaging Trans and Gender Diverse People to Improve Cancer Health Services Research. Lastly, I'd like to give you and invite you for a moment to complete a short 2-minute survey of your experience of this event. So we just welcome your feedback as well as any ideas you have for kind of content you might want to see in future upcoming sessions. So that survey will be prompted by Zoom when this webinar is closed. Thank you all again for joining us today, and I wish you a great rest of your day and week. And happy Patient Safety Week.